joining us for a Kawasaki conversation. I'm Rachel McCormack. I'm the founder of the UK Foundation for Kawasaki Disease. Kawasaki disease is the leading cause of acquired heart disease in children in the UK. So I'm delighted to host this conversation between leading UK clinicians who know this disease and to answer the questions that families and patients affected by Kawasaki disease really want the answers to. Gentlemen, if we could start with a quick round of introductions, please. Rob.
So I'm Professor Robert Tello. I'm a consultant paediatric cardiologist at the Bristol Heart Institute.
Thank you, Rob. Damien.
Hi there, my name's Dr. Damien Rowland. I'm a paediatric emergency medicine consultant at the Leicester Royal Infirmary.
Thank you. Tom.
Hi, Dr. Tom Johnson. I'm an adult interventional cardiologist working at the Bristol Heart Institute.
Thank you. Paul.
My name is Professor Paul Brogan and I'm a paediatric rheumatologist working at Great Ormond Street Hospital in London.
Thanks, Paul. Philip.
So my name is Philip Kutcher. I'm one of the cardiology consultants at Great Ormond Street Hospital in London.
Thank you. And finally, Owen.
Hi, it's Owen Miller. I'm a paediatric cardiologist from the Evelina London Children's Hospital.
Thank you very much, gentlemen. Now, I want to start our conversation with a question which is often present in the minds of many families, and that is why Kawasaki disease is so hard to diagnose. Damien.
So this is a really important question, and there's two parts to this. One is how often a disease is present, and two is how easy it is to spot. So I work in a very busy children's emergency department. Before COVID, we were seeing nearly 60,000 children a year. And in the last 3 years, I have not seen or diagnosed anyone with Kawasaki's disease. Now, what does that mean? That means that either I am missing it, so that there are patients coming through that I'm not seeing, or that it is simply not appearing in my cohort of patients. And there are 4 million children who every year present to acute and emergency services throughout the UK. And if you compare that to the new incidents or the new presentations of Kawasaki's every year in the UK, it's a vanishingly small percentage. It's tiny, the actual number of children who will present to services. Now, that doesn't mean we shouldn't be spotting it, but it's just to give you the perspective that it's very easy for any doctor to see thousands of patients before someone who with Kawasaki's pitches up. The second thing to say, and there's an old analogy in medicine about spotting zebras and horses. So that if you have a zebra and you put it in a field of brown horses, that zebra's really, really easy to spot because it stands out like a flashing red light. If you take all the children who present, for example, our emergency department, those who have had fever, those who have rashes, those who have bumps on their neck, those who may have some funny changes in their fingertips, they're all very common occurrences. And so that when a doctor is trying to spot specifically Kawasaki's disease from all the other children who have slightly similar symptoms and it being very rare, it becomes very difficult to do so. If it's your child and you're aware of what the diagnosis is, or you're aware afterwards that Kawasaki's has been missed, it's very easy to say, but it was obvious. There were all these things. But the retrospectoscope, it's another medical term about looking backwards, is much easier to do backwards than it is at the actual time. And the last analogy I'll quickly give is every year, unfortunately, a parent will accidentally leave their child locked in their car because they've forgotten to take them out of the car seat, and they will drive past the nursery and just go to work. And you can think, how could you possibly do that? Someone who loves their child so much. But we get into routines, and Kawasaki's is not a routine disease. The routines we see are coughs, colds, wheezes, funny rashes, and it's trying to make sure that doctors don't get into a routine way of doing things, and that's the way we're going to help them spot this.
Thanks, Damien. Rob, you saw me smile and you smiled. What am I going to ask you about?
Is Kawasaki disease very rare? And I think it's really tricky, and I quite agree with Damien's comments. You know, we heard very eloquently that the doctors at the coalface seeing general pediatrics will see children with fevers and a cold or a cough or a rash. That is common. However, Kawasaki disease is also increasingly common, and we need that doctors and allied healthcare professionals to think of this as a diagnosis. We did a British Pediatric Surveillance Unit study over a 2-year period, and we saw 600 children with Kawasaki disease across the country. And this is probably only about 2/3 of the number of children that were actually out there. They were voluntarily reported to us. So several will be missed, or the doctors were too busy to let us know. So for me, 600 children is a lot of children. A lot of children with Kawasaki disease. And in fact, in our Bristol and Southwest clinics, we've had nearly 600 children in the last 15 years alone, which is, again, for me, quite a lot of patients. But I would say that because I'm interested in Kawasaki disease, and so hopefully I see many of the cases. I think one of the other things that Damien's right is that there are children who are young and who have the worst disease, who are under 1 year old, and they tend to have the fewest symptoms. We found that in our study, over half of the children who had cardiac involvement, who were under 1 year, only had one other symptom apart from a temperature. That tended to be a rash. So you're talking about children with just a temperature and a rash. Over half of them had Kawasaki disease and had cardiac involvement. And that's really difficult, and that explains why it's so hard to pick up. We tended to find that children who are older, perhaps those who are 2, 3, or 5, or even older years old, may have had more of the symptoms. And in fact, if they had all 5 of the features plus a fever, then only 17% of them had cardiac involvement. So some of this is the fact that disease is not being picked up because it's difficult. Some of this is because infants tend to have worse cardiac disease. And some of it's because it's diagnosed later. People wait until other of the symptoms have appeared, and therefore by this time they've had the cardiac involvement.
Thanks, Rob. I think it's 53%, isn't it, of infants that have cardiac involvement, and very, very few symptoms. So it's really, it can be difficult to identify Kawasaki disease. And as you've said, considering Kawasaki disease, and you said as well, Damien, you know, it's important to be alert to considering it, because when we label things as rare, very often they're put to the back of our minds and or forgotten about. And a big part of our work of Society is raising awareness of Kawasaki disease, so it is considered and not considered too late.
I'd just like to ask Damien at that point. Damien, what features, when you're seeing somebody in the emergency department, says this child must be that one that's got Kawasaki disease? What's the key feature that you would say to other pediatricians says, really got to think this one's Kawasaki?
So I try not to think that way because the moment that I start looking for specific items to hang my hat on is the moment that I miss things. And it's interesting. This is a really good debate about what is rare. And I think clearly from a numerical perspective, 600, 1,800, if you multiply by 3, isn't rare at all. But if you take it on from the individual doctor seeing the patient, we have to look at it from a frame of who are they going to spot in any given time period. How I try to make myself not be cognitively biased, I just get into the same way of doing things all the time, is double check myself to confirm that what I'm seeing fits the diagnosis I'm making. And for me, the Kawasaki's disease I've spotted, there is always something subtly different that takes it away from the run-of-the-mill cough and cold. And the thing to me has always been the irritability. And there's something about the parent's description of their child that stands out, that is different from just a child who has a runny nose, even if they happen to have the other kind of symptomologies as well. I think you're right to point out this under one group. One of the really good things I think that come out of the new NICE guideline review is this push to get doctors to start thinking about some of these atypical presentations. Certainly the really young group are very difficult because they don't have this classic kind of all the 5 symptoms, and also thinking about maybe diagnosing it earlier than 5 days. That's a real medical school way of thinking, is actually you can only diagnose Kawasaki's if you have this, this, and this. And again, that leads to error because you're trying to package something. So what I'm really attuned to is really listening to what the parents are saying to me and trying to work out if they're concerned about the symptoms or they're concerned about the child. This has served me well throughout my pediatric emergency medicine career. The moment a parent is fixated by a symptom, I'm not so worried. If they're worried about the fever or the vomiting, the kid's normally okay. It's the moment they say, there's something wrong with my child and I don't know what it is. And then that's when my ears pick up, and then that's why I start thinking Kawasaki's.
And there was just 3 points I wanted to add about why is Kawasaki disease so difficult to diagnose. I think that there are 3 important diagnostic pitfalls that I don't think we've completely mentioned. One is the sequential nature of the clinical signs. In other words, patients might retrospectively have a full house of Kawasaki features, but at any one time when they present to medical doctors, the full house isn't there. But you can score the features retrospectively. So that's the first thing that may increase your diagnostic rate. The second thing is that there is absolutely no diagnostic test for Kawasaki disease, but a C-reactive protein, a simple blood test that's available in every hospital around the world, can be incredibly useful for raising your suspicions, because the vast majority of viral infections are not associated with an elevated C-reactive protein, but in Kawasaki disease, it's rip-roaring. So if you think it might be viral, but you've got a very high CRP, think Kawasaki disease. The very last thing is that if some bright spark has thought of Kawasaki disease but has done an echo, and the echo is normal early on in the process, please do not say that it's not Kawasaki disease, because the vast majority of patients will have a normal echo, and that patient might develop cardiac problems at weeks 2, 3, and 4. So do not exclude Kawasaki disease on the basis of a normal echo. So I think these are 3 important diagnostic pitfalls that I've found helpful over the years.
Damien, go on.
And I suppose just to make the situation more difficult, I entirely support Paul's comments at all 3 points, including the raised CRP. But you've got to do a blood test to know it's high in the first place. And the challenge is that we don't routinely do blood tests on children we perceive to have simple viral illness. And there are good reasons for that, because if we did blood tests on every child that we had viral illness, we would be overwhelmed and wouldn't be able to function. So sadly, the challenge is you need to pick the right person to do the blood tests on, and then you need to be able to spot those blood tests. And that just makes the conundrum even harder.
Philip, could I turn to you? Damien's talked about a number of symptoms. Rob mentioned the heart damage that can occur. A lot of parents are concerned about aneurysms necessarily, even when their children are not diagnosed with cardiac aneurysms during the acute disease. And it's something that says heart disease and Kawasaki disease we know can go hand in hand all too often. About 3/4 of children affected by Kawasaki disease don't develop coronary artery aneurysms. So for those children that don't develop them initially, will they go on to develop them later?
Thank you, Rachel. So as you mentioned, there is about 20% of children appropriately treated with Kawasaki disease that do develop some coronary artery changes, and it is even more in the less than 12 months category, where it is approximately 40%. So the reason why patients with Kawasaki disease develop coronary artery aneurysms is because the process, the inflammatory process, damages the wall of the vessels, which basically leads to them being weak and not being able to resist the pressure within the arteries. So the way we screen for these changes is with serial echocardiograms that starts basically whenever the child is referred to our service. but we rarely see changes before, I would say, the first 2 weeks of the disease. So typically, the very first changes can be spotted on echocardiography within the first 2 to 3 weeks. I think you will agree that it is extremely rare to see new changes to develop in previously normal coronary arteries after 6 weeks, and this is basically when the inflammatory process settles down and is basically switched off because of the treatment we give. So the peak of changes is usually 2 to 3 weeks, and rarely it is after say 6 weeks. I think what is also important to stress is that patients that do not develop coronary artery changes, that there may be other changes that some people may not be aware of. There's some evidence suggesting that these patients that basically having a history of Kawasaki disease is a risk factor for atherosclerosis, is also a risk factor for abnormal reaction of the coronary arteries to various molecules that regulate the flow across the coronary vessels. So these are all risk factors that put our patients with a history of Kawasaki disease in a higher risk cardiovascular category on the longer term. So to answer your question, I think it is extremely unlikely for patients to have new aneurysms after 6 weeks of the disease, and this is also why, for example, the American guidelines suggest that patients can be discharged after this period of time. And as I mentioned, the peak of the changes is usually after the first 2 weeks of the disease.
Thanks, Philip. That is an issue that does concern a lot of parents whose children haven't had heart involvement initially, so I'm sure that'll be very reassuring. Owen, could I turn to you? We know Kawasaki disease is an inflammatory disease and it can affect all major organs. So why, when assessments are conducted, we look at very carefully at the coronary arteries, but why aren't assessments conducted on other arteries or on the brain?
Yeah, so I guess you've got to go for where the money is. I think, the diagnosis of Kawasaki's is difficult anyway, and it's often missed, it's often incomplete, and sometimes it's not even considered at all. The predominant complication, or the major complication we worry about in Kawasaki, is coronary aneurysms. And as we've heard from the other speakers and from you, it's in the minority, but a significant minority of cases with Kawasaki disease. And therefore, it's really important to evaluate the heart and the coronary arteries, and that should be your primary focus. Obviously, you've got to be managing the child, managing the acute inflammation, etc. But as a cardiologist, it's really important to understand, is there inflammation of the heart itself, or myocarditis? Is there inflammation of the coronary arteries and arteritis? Are the coronary arteries normal, or are they dilated? So that for me is the primary focus. Now, aneurysms can occur elsewhere, but it's very difficult to do generalized imaging of the whole body. It is possible and has been done. And many children with Kawasaki's, as we heard at the beginning, have irritability, behavioral disturbance. So you might think, well, maybe we should be imaging the brain more often. I think the yield, what you get from doing that is further delay in making the diagnosis, further delay in looking at the heart, and maybe delay in treatment. So I think it's really important to make a clinical diagnosis of Kawasaki, to get the inflammation turned off as soon as you can, to start the accepted treatments, and to look at the heart. Then, if things are abnormal, if you've got persistent fever, if you've got rapidly developing aneurysms, if you've got other signs or symptoms, then you can image other parts of the body. MRI is a good way of doing that, no radiation based, but in small children it is a general anesthetic to do that. So I think what you need to do is manage the child and investigate the heart as a priority, and the other things would be, for me, secondary, and certainly not in the majority of children. That would be in a small number of children. So I would go where the value is, and it's looking at the heart and making sure there aren't coronary aneurysms.
Mm-hmm.
happy to hear disagreements if people do image other parts. We don't do it routinely, but we certainly can do it. But it's not routinely available in all hospitals, sort of that sort of more detailed imaging of other body organs.
Paul?
I agree with Owen. It's a very good rule of thumb, and it was a Kawasaki disease doctor from Hawaii who taught me this back in the late 90s, called Marion Mellish, and she had done some work that had strongly suggested that if you do not have coronary artery changes, then you don't get the vasculitis anywhere else in the body. So if the heart is normal, there's no point in looking elsewhere. Owen is absolutely right. If you've got severely damaged coronary arteries and other features, for example, the inflammatory markers not settling or a very high blood pressure that's unexplained, at that point it's useful to look elsewhere, because there can be damage to the renal arteries, but they always happen in the context of demonstrable changes on the coronaries. So if the coronaries are normal, the rest of the arterial tree will be normal.
Go on, Rob.
And I was going to say, I mean, I too agree. And I think it's also worth pointing out that the treatment and the management of somebody with aneurysms elsewhere would be exactly what you're already giving the child for the coronary arteries. So if they've got risk of clotting up other blood vessels, they will be on blood thinners, which will be helping their coronaries and elsewhere the other aneurysms. So they're already on the right treatment, which can be beneficial.
I mean, you touched on numbers of tests and some risks associated with certain tests, and presumably that's another consideration, isn't it, that doctors think about when making a judgment in terms of both a diagnosis and a course of treatment?
Yeah, absolutely. So, you know, we know that we can do high quality echocardiography, ultrasound of the heart and the coronary arteries in almost all children, and get, in many cases, spectacular images. Now, that is a non-invasive, risk-free procedure. Now, some children might require sedation to get good echocardiography. And we've gone over, in children who have got coronary artery abnormalities, we've gone over to early CT scanning. So we're doing CTs of the coronary arteries, but we're doing CT because we can do that now with the new modern machines at very low X-ray dose, and we can do it without any anesthesia. It takes about less than a minute to do, and you get very high quality. Now, we don't do that in everybody, but if we see coronary artery abnormalities, we find it very useful to do something like a coronary CT as a baseline for future assessment. But once again, that is in a minority of children with Kawasaki's. Most children with Kawasaki's, you can manage and you can investigate them with non-invasive ultrasound, which doesn't require catheterization, general anesthetics, injections, and can be achieved either just by soothing the child or by sometimes gentle sedation.
Thank you. Paul, did you have any final reflections on that?
No, I agree with all the previous speakers.
Okay, super. Well, Paul, if I can stay with you, if that's okay. We talked about aneurysms a little bit, and we know that in some children, when there is dilation, aneurysms will resolve. We don't talk about them normalising anymore, but we know the arteries remodel. What changes might you expect, if any, in aneurysms that have remodelled?
So it's a counterintuitive thing. If you see the aneurysms shrinking down on the echocardiogram, many people might feel reassured by that. I tend to be rather more pessimistic, because when aneurysms heal, they're healing by a process of fibrosis, and the concern that many doctors might have is whether the arteries will continue to narrow and narrow and narrow until, of course, they start limiting blood supply. And indeed, that's what can happen with children who have got the severest aneurysms, particularly at the inlet or the outlet of that aneurysm. And it's stenosis is what us doctors call that, causing the blood supply to the heart to be compromised. We also know that even when arteries do heal, that they don't behave like normal arteries. They're just generally a bit stiffer in the coronaries, and Philip alluded to certain tests you can give, pharmacological stimuli that demonstrate that the arteries don't relax as well as those of children who have not had Kawasaki disease affecting the coronary arteries. About 20 years ago, we used to worry that it did indeed predispose to atherosclerosis, but when you have severe coronary artery disease years after Kawasaki disease, and you do happen to have a problem with that, what we now understand is that the histologically, in other words, under a microscope, it looks different from atherosclerosis. In other words, it's a late healing vasculopathy after Kawasaki disease, and strictly speaking, not the same as atherosclerosis. We also know that if you study hardening of the arteries in the peripheral arteries, for example, in the arms or the legs, there's no evidence that in fact they've got hardening of the arteries elsewhere. So the concept that there may be a late Kawasaki disease coronary artery vasculopathy that might be distinct in some way to atherosclerosis or hardening of the arteries is what seems to be emerging.
Tom, I don't know whether you want to offer any thoughts. Perhaps I'll go to Philip first. You've got your hand up, Philip.
So I think Paul mentioned a very important point, and this is about screening for what we call stenotic lesions. So basically narrowings of the coronary arteries that develop years after the patient had a giant aneurysm, for example. And therefore, in all patients with severe disease, we do what we call stress testing. So these patients, they have either what we call stress MRIs or stress echocardiograms. So basically, we study how well the heart muscle is perfused with oxygen, whether there's any lack of oxygen in one of the segments of the heart. And this basically helps us to sort of screen for these lesions, which are one of the major causes of mortality and morbidity in these patients years after the onset of the disease.
Tom, I was going to come to you just to help us put a little bit of quantification around this years after. If you're a parent, it's easy to think about years being 2 or 3 or 5. What sort of time frame are we thinking about here?
Yeah, so obviously as an adult cardiologist, I have a very different perspective, I think, and very fortunately through working closely with Rob in Bristol, we have developed this adult clinic, which is, I think, critical in terms of offering a transition from the paediatric service to adulthood. And actually just listening to what's been said, the thing that strikes me most is that the psychological aspects that I think impact both the child and the caregivers quite substantially, and our uncertainty in terms of how things are, I think plays out in their inherent concern as well. And we've heard about the importance of imaging, and so in childhood use of echocardiography. And I think one of the things that we do first when we meet with a family is to consider the facts. Do we know whether there has been coronary involvement and regression, and where are we heading? And so we have those discussions about the use of CT, so being able to use a non-invasive test, something that means we're not prodding and poking with tubes and placing risk, but balancing that for the long term in terms of not wanting to expose unnecessarily to repeated X-ray exposure. But actually the benefit and the potential reassurance of a baseline CT scan to say yes or no, there appears to be involvement of the coronaries, I think is essential. And then actually taking it another step further and exercising patients. There are a number that I've brought to treadmill testing and done that on actually a personal level, attending, because there is this loss of confidence and kind of uncertainty about what can be done. And physical exercise, we've talked about the need to modify risk factors, are all very, very essential elements of living life and minimizing future risk. So for me, actually, the psychological impact is the bit that I think we need to probably focus on more in that transition phase, with then a kind of grappling with the extent of disease and the long-term risk management that then follows. And that kind of played out very much in the discussions we've already had. I think that our uncertainty is probably as unsettling for the patients as much as anything.
Mm-hmm. we will come back to a little bit later, lifetime management and care, and the structure that the new guidance does put around us as families, but also is offered to yourselves as clinicians, because I think that does a pretty good job of taking some of that uncertainty and subjectivity away. But if I can turn to Philip and a topic which is very current indeed, COVID-19 and the emergence of PIMS-TS. It is something that as a scientific advisory board we've done quite a bit of work on in terms of reassuring parents and answering questions that parents and patients put to us. But could I ask you, if children have previously had Kawasaki disease and they contract COVID-19, is there any evidence to suggest that they're at a greater risk of getting PIMS-TS?
So thank you, Rachel. I will try to answer this question to my best knowledge. So as you know, PIMS-TS stands for pediatric multisystem inflammatory syndrome temporarily associated with COVID-19. And this is basically a dysregulated immune response after, usually it is 2 to 4 weeks after exposure to COVID. So many of the patients do have a negative testing either by PCR or by serology. So this entity was only defined in April after a cluster of very unusual presentations. And there's still a lot of unknown about the disease, and many of the questions will need to be answered, I think, in the next couple of months or years. So what do we know from the first wave is that 70% of the affected children were from Black, Asian and minority ethnicities. We are talking about relatively small numbers compared to the number of children living in London, for example. So if I'm not wrong, there's about 1.5–2 million children up to the age of 18 living in London. And I think there were up to a few hundreds of children with suspected or confirmed diagnosis of PIMS-TS. So very, very small numbers compared to the adult population. And there's been a lot of discussion about whether PIMS-TS is a variant of Kawasaki disease or whether PIMS-TS is causing coronary artery dilatations. So as I said, we are probably early days to answer this question in a good way, but at least from my experience from Greater Ormond Hospital, what I can say is that we think that PIMS-TS and Kawasaki disease are two different entities. So looking back on the numbers from 2019 and to what is happening now, so I think what is important to stress is that there's a number of clinical conditions associated with minor coronary artery dilatations. This can be sepsis, this can be a number of rheumatological conditions, sickle cell disease, for example. And these are really minor dilatations that are non-specific and then just resolve with time. So if we take the patients with more than just minor dilatations and compare it to 2019, at least in our group of patients, the numbers were, I would say, relatively similar to 2019. So obviously many of the PIMS-TS has a lot of clinical features that are similar to Kawasaki disease, or what you call a toxic shock syndrome. So we don't think, based on the data at least we have from Greater Ormond Hospital, and this is not a UK experience or something that would be universal. I'm just talking about my personal experience from the first wave. I believe that Kawasaki disease is just different. And what is also important to mention is that Kawasaki disease is 40 times or nearly 40 times more common in Japan than it is in the United Kingdom. And therefore, we would expect, if this was a risk factor for PIMS-TS, we would expect a huge peak of PIMS-TS in Japan, and this is definitely not the case. So again, I think this is a piece of evidence to say that our patients with Kawasaki disease are probably not at risk of developing PIMS-TS.
Rachel?
Damien, yes, please.
Just really as a quick aside, I know some of the information that came out to the general public during COVID, and especially the PIMS-TS, caused a great deal of anxiety because there was a great deal of uncertainty about what was going on. Maybe this is putting too much spin on it, but the positives of what has happened has been increased awareness. And I spent my beginning to talking about how difficult it is to spot, because in the cohort of children we see it's not common. anything that makes people think about, could this be different in exactly the same way? Could this be sepsis? Could this be Kawasaki's? Is a good thing. And I think there has been an opportunity here that many doctors who have either forgotten about Kawasaki's or it's not on the forefront of their mind, it now is. And if we're going to take anything positive at all from what's happened over the last couple of months, that would be it.
Yeah. Owen.
Yeah, I agree with that. And I think the other benefit that we've seen is that, we've seen a lot of PIMS TS at the Evelina London, and across London there's been quite a lot, and it's been also seen across the UK. But what we've done is use the same team. The Kawasaki team have been the team that managed the PIMS TS, because there are differences and there are similarities. And it's good to have, I think, a group who are get immunologists, infectious diseases, rheumatologists and cardiologists in the room together to manage these children with inflammation. And I think it's improved our management of Kawasaki, because we're seeing more children with inflammation. We're working better together. So I think there has been a positive spin-off. I know that there was concern about the early press reports of Kawasaki-like illness, etc. But in fact, I think we do differentiate them from Kawasaki and PIMS, but I think the teams are working much better together, and I think that's been a positive result.
Thanks, Owen. Damien, you're absolutely right to flag up the raising of awareness, and as you say, it's some comfort that it is very much more on the minds of clinicians now than it has been at times in the past. I think it's fair to say too that parents of children who have had Kawasaki disease, because of the coupling of the language and the sort of clunkiness of the reporting early doors, it created an immense amount of strain and worry. And I'm sure that's where that question that Philip just answered came from. It's still in people's minds. And of course, as our children go back to school, as they are doing at the moment, it remains in people's minds. So thank you for the positive reassurance. Paul, I don't know whether we talked quite a bit about Kawasaki disease and PIMS TS. I don't know whether you've got any final reflections before we move off topic.
Yeah, I'm very impressed by the level of the conversation amongst the experts. If it was one of my teenagers that developed PIMS TS, I'd be very happy for any one of these doctors to be looking after them. I think they're very thoughtful. So I agree with what everyone has said. I just want to say that, if ever there was a time for clinical acumen, it's now, because Kawasaki disease has no diagnostic test. PIMS TS has no diagnostic test. And the definition of PIMS TS includes features of Kawasaki disease. So what on earth is a clever doctor meant to do? Well, all you can do is bring to this the art of medicine and try and sniff out the differences between the two. And there are some signals, but I would agree with everyone. I think that PIMS TS is different from common or garden Kawasaki disease, and the Venn diagrams overlap, but not necessarily with the same cardiac complications as we worried about at the beginning of the pandemic.
Thanks, Paul. I think you've said previously as well that if it looks like Kawasaki disease and you think it's Kawasaki disease, it probably is Kawasaki disease. So let's treat it as Kawasaki disease, and there's a lot to be said for that. Rob, could I just turn to you and think about some of the longer term effects that children appear to experience after having had Kawasaki disease? We've talked a lot about the coronary and cardiac implications of it, but a lot of families identify joint pain and behavioural issues, night terrors. Are these things consistent with Kawasaki disease? Would you expect to see them? Are they linked?
Yes, it's a really good question. In fact, the commonest reason that children are referred to my long-term Kawasaki disease clinic is for non-cardiac reasons, which is a bit strange being a cardiologist. And it's often the behavioral changes, it's the mood changes, it's the sleepless nights, it's the eczema, it's all the other rather strange features of Kawasaki disease. But if you think about it, it is what we call a multi-system vasculitis. So it affects the small to medium blood vessels across the whole body. And as we've already talked about, it's not surprising that other organs are affected. We did a study nearly 20 years ago now, which showed that a third of children with Kawasaki disease had behavioral changes, both acutely and over the first couple of years. We did do brain blood flow studies using a thing called a PET scan, which is not something we use very often, but it did show that at the front of the brain, the behavioral changes were linked to abnormal blood flow. And a lot of parents come to me and say, like, I've got a 2-year-old child who's got bad behavior. Is this Kawasaki disease or is it not? Or I've got a child who's 12 years old and he's not wanting to go to school and he's displaying autistic tendencies. Is this Kawasaki disease? And of course, it can be very difficult to be sure. And I generally say to people that anything can happen. I've seen pretty well any symptom you care to mention following Kawasaki, but most of these things will settle over the first couple of years. That if you have behavioral changes, you have mood changes, you have night terrors, they tend to get better over the first couple of years. It's not surprising that many of these children will have been in hospital. They will have had their sleep disturbed. They would have had needles. They would have had drips. They would have had nurses taking observations at 3 in the morning. The families will be anxious. They'll be worried about long-term sequelae, long-term consequences. So it's hardly surprising that there are behavioral problems and family anxiety and childhood anxiety following an episode. And as Tom has already said, it's one of the things that we find a real issue by the time people are progressed into the adult clinics, that the child, now the adult, and the family or the siblings or the parents or the partners are concerned about the long-term consequences. And there's a lot of anxiety and a lot of psychological problems which we need to unpick. And quite often we're providing reassurance. Quite often we'll be able to do a scan and say, as far as we can see, there isn't a long-term heart problem. Go away, live your life normally, and really don't worry about this. So the behavior changes, the mood changes can be a feature, but generally they get better. And I try to encourage parents with good parenting skills, lots of reassurance, lots of supporting the child, and as a doctor, lots of supporting of the family. You talked about some of the other features, joint pains and skin changes. We often see eczema. We often see a patch of eczema, especially on the bottom or the upper leg after an episode of Kawasaki. This is clearly part of the inflammatory response that we're seeing. And I do just throw in a little caution. If somebody's having a lot of joint changes, a lot of joint swellings following an episode of what was thought to be Kawasaki disease, just keeping the mind open that it might be something else, rather more in Professor Brogan's ballpark of the rheumatological. There are many joint conditions which can present a little bit similarly. So making sure that the doctor relies on his clinical acumen, brings all these different issues together is very important in order to make sure that the residual effects aren't just put down to Kawasaki and there's not some other condition underlying it, which we could miss.
Thanks, Rob. Well, you mentioned in dispatches. Have you got any comments?
Again, I completely agree with what Rob has said, and I think that the biopsychosocial aspects, it's a child with an inflammatory disorder that may have spent many days or even weeks in hospital will be traumatized. The parents are traumatized. The child is traumatized. And that trauma can manifest in many somatic ways in very young children. Also, I'm a little bit cautious about attributing things that occur in the skin years down the line, to Kawasaki disease, because eczema can occur commonly. And certainly it's a question that parents have. Might it be linked to Kawasaki disease? And my approach is, well, of course it might be, but there's no hard evidence. These things can occur. Kawasaki disease does not protect you from developing other illnesses throughout your life, is what I usually tell them.
Thanks, Paul. Owen, Philip, please.
No, I think Rob summarized very nicely the longer term effects, and I would just like to stress one detail, and this is that in some children that are resistant to the standard therapy, we use high doses of steroids, and then this treatment sometimes also causes behavioral changes, but this is on the short term in the acute phase.
Owen, Still thinking about long-term issues, but in relation to medication, a lot of patients are given a low dose of aspirin for a long period, sometimes for numbers of years or sometimes indefinitely for life. Is there a risk to health if the dose stops after a period of time?
Well, I think the short answer. So I think aspirin. We need to be very clear about aspirin. And differentiate the sort of the high dose aspirin that's used in the acute phase and the low dose aspirin that we're using long term. And the acute phase aspirin, you know, you can argue really to the cows come home about what effect that is having, but that's being used in an anti-inflammatory effect rather than anything else. The low dose aspirin, and we're talking, you know, 3 to 5 milligrams per kilogram, up to a maximum of about 75 milligrams once a day, is used for a different purpose. And that's used to stop the blood, the platelets sticking together to make the blood flow more smoothly through arteries which might be inflamed, might be dilated, or might be narrowed. So we need to firstly differentiate between high dose and low dose aspirin. Couple of other important things also is we don't know, and we said this earlier, in this first 4 to 6 to 8 weeks, we know there has been inflammation going on, and we know that it will take time to settle, and therefore even if the child has no sign of cardiac involvement, certainly all the recommendations, and I'm sure all of us do the same thing, that we would treat all of these children with low-dose aspirin for a minimum period of 6 or 8 weeks, even in those who show no evidence of coronary artery involvement. And then in the longer term, those who do show coronary artery involvement, what we're trying to do is we're trying to give something daily to stop a rare but very, very serious complication of coronary clotting in the coronary arteries, coronary thrombosis, which would be a very serious complication. So we're asking families to give a medicine to prevent something which may never occur. So there is that psychological barrier you've got to get across. You know, you're asking to give them something every day of the week and month to protect them from something which may not occur. Now, I'm very relaxed about aspirin. I'm very relaxed about giving low dose aspirin long term, and I have really very few reservations about doing it. I would have reservations about children who about stopping suddenly in children who I think have abnormal coronary arteries. You know, I think it is important that if the Kawasaki team have said, you know, we want you to continue aspirin indefinitely, then everything in life is a risk-benefit analysis. But the risk-benefit analysis is in favor of continuing the aspirin. And so I think our job is to reassure families that low-dose aspirin is safe and can be used long-term. And just stopping it because the child looks or feels well does carry some risk. We've also got to, I think, mention the other interactions. You know, there's interactions with other medicines. So certainly for families who have children on long-term medications, then we need to be aware and alert for interactions like, you know, ibuprofen, the effect of that has blocking the aspirin effect on platelets. We need to think about if children have symptoms. You know, we can't attribute if they've got tummy pain or discomfort. We can't always say, oh, well, it must be the aspirin. We have to think that through. And then there's the risk of when a child gets chickenpox or influenza, the risk of, you know, this rarely described Ray's syndrome. Well, you know, I think that's overplayed, quite frankly, myself. You know, Douglas Ray was a pathologist at my hospital in Sydney and described this, you know, over 60 years ago. And it must be about 25 years since I've seen a case of Ray's syndrome. So, you know, I think this is, I think it's much more important to get children immunized against influenza. And I think it's much more important to recommend immunization against varicella chickenpox, is my own personal view. But, you know, the recommendations are the recommendations. And if a child is on aspirin and they get chickenpox, fever, influenza, then they do have to stop aspirin, and we have to, you know, change it to another another type of medicine. But we don't want families just stopping and starting and stopping and starting without discussion. I don't know whether that answered your question or whether I just went off on a tangent there.
No, it was brilliantly answered. Thanks, Owen. And Paul?
Just one thing I want to add to that. To reassure parents, so for example, if there is a concern that the child develops chickenpox and the aspirin has to be stopped temporarily, the effect of aspirin, even when you're not taking it, can still be beneficial to the platelets up to 3 weeks later. It was one of the first experiments that we did on ourselves in medical school to demonstrate that, where we all were given in our first year in St Andrews University a dose of aspirin, and then 3 weeks later we're still doing a blood clotting test on ourselves, and the effect was so even if parents have to stop it for a few days, the effect will still be there, affecting the platelets, protecting their child from a blood clot.
That's really helpful. Thank you. Paul, can I stay with you and just go back a little bit and look at, have a think about longer term skin conditions. A number of families raise the concern about long-term issues, long-term issues that may or may not be associated with Kawasaki disease in terms of dermatological skin conditions.
So there are 3 long-term skin conditions that have been described in association with Kawasaki disease, and only one of them, I believe. And the one that I believe is the one that Professor Tullow taught us about maybe about 20 years ago. And I do warn my patients about it. It's the phenomenon of repealing. In other words, you have your Kawasaki disease, Dr. Miller and Dr. Kuchera look after you perfectly, and you come out and your heart is completely normal. And then about 6 months later, your child develops a cough and a cold, and the fingers go red and eventually peel. Oh my God, has the Kawasaki disease come back? Well, the answer is probably, or almost certainly not. But there is this funny thing called repealing, where the immune system seems to remember, and when it sees another virus or whatever, becomes activated and induces this rather benign inflammatory reaction where the skin can repeel. What I can never remember, I'm hoping to ask Professor Tullow this, is how many years does this go on for? Because I usually say after a couple of years it's probably no longer a concern, but by that time I've discharged most of my patients, so how on earth would I know? And before you answer that question, the other 2 things that are described in the medical literature is this guttate psoriasis, and as Professor Tullow mentioned, eczema, but I think both are relatively common in childhood anyway, and whilst they might be attributed to Kawasaki disease, I'm a bit of a non-believer there. So Rob, the question to you is, how long can repealing go on for?
And I think it's a really good point. And I tend to say, as you, that most of these things settle down within the first couple of years. And often have parents coming to me and saying that my child has got a weak immune system. Every time they get a cold or a cough, they get a raging temperature, they get red eyes, they get repealing of the fingers, and it's all because of the Kawasaki disease. And just like you, I tend to say a bit the opposite. I tend to say that the immune system is primed, it's ready to go, it remembers having had Kawasaki, and whether this is because there's some underlying predisposition to having a very marked inflammatory response, or whether it's because the Kawasaki disease has fired up the immune system, I'm not quite sure at the moment. Certainly from the eczema point of view, I agree in the long term. I do tend to see early on, after a period of Kawasaki, the parents say to me that he's had, an illness. Was it Kawasaki or was it not? I didn't see them in the acute episode. And I say to them, did he have a patch of eczema on the bottom? And they say, oh, yes, he did. It tends to add a little bit of strength. But this is early on after the illness and certainly does not go on any more than a year or 2 after the acute phase.
Thank you. Paul, you mentioned repealing being benign, and that means it's not harmful. Is that right?
Yeah, that's right. And of course, most of the parents these days have been on the internet and have looked up that Kawasaki disease can recur. So it is true in Japanese patients that Kawasaki disease can recur, but in the UK population or outside of Japan, I really think it's rather rare that Kawasaki disease recurs. But parents might be alarmed when they see this, and it will remind them of when their child had Kawasaki disease. And if there's any doubt, it's often reassuring for patients to have a repeat echocardiogram if there was any doubt whether it was just a benign or mild repealing versus a true full-blown recurrence of the Kawasaki disease, which would be exceptionally rare in my experience.
Paul, can I just ask you, if we think that Kawasaki has a genetic component, parents have read this, they may have taken part in some of the genetic studies. What do you think about the increased risk for siblings or parents had Kawasaki disease and running through the family? If it's genetic, then surely that must happen.
Yeah, it's a great question, and if you'd asked me that 20 years ago, I would say, yeah, it's probably a lot of rubbish, and no, it doesn't. But then I came across two identical twins, two Caucasian twins at the beginning of my career, and twin one came in at 8 weeks with Kawasaki disease and coronary artery aneurysms, and we warned about twin two, and he represented 6 days to us with reactivation of a BCG scar. So the question is, well, is it because twins are exposed to the same bacterial toxin that triggered the immune system, or is it a true genetic link? And we don't know. I'm going to say something rather controversial. I think that the genetic case for Kawasaki disease is overplayed. In other words, it's true that there is a genetic link, but it's not like cystic fibrosis where there's one single gene that's faulty. It's more than likely sets of genes. So this endless hunt for the single genetic variant that's going to explain your risk, I think, is a hunt for fool's gold amongst the Caucasian population, and hence why it's not been discovered yet.
Controversial as always, Professor Bergen. Thanks, guys. That's really helpful. Turning then to thinking about follow-up treatment and lifelong care, perhaps I will turn to Tom in the first instance. We've got a number of young adults and older adults who've had Kawasaki disease, perhaps had cardiac involvement. What are the current guidelines for follow-up treatment?
So we've actually all been involved in developing some UK-based lifetime management guidelines, which was really important, I think, at firstly just raising a flag, raising awareness amongst colleagues that this is something that needs to be done. And so clearly in the paediatric setting, there's a greater awareness, although we've already heard there are concerns there in terms of not identifying. In the adult setting, that's the even greater concern. So there are a couple of aspects in terms of management. One would be the children, as we've already touched upon, transitioning from paediatric care to adulthood. And then clearly we have a difficulty in terms of spectrum of disease. So we have those who've had Kawasaki illness and then don't appear to have coronary involvement. And I think that transition then is, as we've already emphasised, this need for reassurance, and actually maybe an opportunity to draw a line under the events, discuss ongoing risk management, so minimising risk as much as possible, but returning to exercise, doing everything that should be kind of offered, versus then at the other end of the spectrum, those who have significant aneurysms, significant swelling of their coronary arteries, where clearly the risks are greater and we have to think more carefully about the ongoing management. So we've touched upon aspirin, but clearly in the setting of large aneurysm, there's the need for more aggressive blood thinning, so the use of warfarin in combination with aspirin. So there's a spectrum of discussion that needs to take place there in terms of the ongoing care. And then Paul's already mentioned about this issue about regression, about the aneurysms reducing, and whether that truly is the swelling reducing or whether it's due to an ingrowth of tissue within the artery, and this risk then of there being significant narrowing develop, either at the inlet, the entrance to the swelling, or the exit. And that then is leading to us having to think more carefully about ongoing follow-up. And so we would suggest that any child that has evidence of aneurysmal swelling, regardless of degree, should probably undergo some form of annual review. And I think we're learning as we go in terms of what that encompasses. Absolutely, some face-to-face or now virtual clinic time I think is important, but using imaging to better understand how these aneurysms progress or quiesce, kind of settle, is really critical. But for me as an adult cardiologist, I think the element that's most unsettling is the patient that presents without a history of Kawasaki disease, but with clear-cut aneurysm. And we know that, you know, a proportion of patients who present with heart attack come with previously undiagnosed aneurysmal or abnormal swellings of their coronary arteries. And then we're in another difficult place where we again have to be fairly clear in terms of our ongoing guidance. And that's where awareness within the adult cardiology group is so key in terms of ensuring these patients are adequately protected for the future with blood thinning treatment, aspirin and warfarin.
Thanks, Tom. Rob, in terms of a paediatric patient that needs ongoing care, what Tom's talked about spectrums of disease. What's the considerations for a younger patient and ongoing care beyond the acute disease?
No, I think it's a really good point. I think the first thing that I would say is that it's really important that children who are deemed to have never had coronary involvement, to have had normal coronary arteries, that they should be reassured and discharged at the appropriate time, somewhere in the first few months after the initial episode of Kawasaki disease, because most children will go away with no long-term sequelae and can be reassured. And we certainly wouldn't want people to be worried that they're going to have undiagnosed cardiac events later on if they never had heart involvement at the beginning. Then for those children who've got abnormalities, they had a coronary aneurysm, then I think it's important that they are seen regularly in a clinic by doctors who are familiar with Kawasaki disease. It should be in a clinic, ideally a Kawasaki disease clinic, which may be involving several different types of doctors. It may have a psychologist, it may have a nurse, may have a rheumatologist, infectious disease, a cardiologist, other people who are particularly interested in Kawasaki disease and who know what they're doing and who know what the follow-up is arranged for them. And as Tom has already said, those children who've got significant coronary artery changes have to follow a very carefully defined pathway with regular follow-up and investigation. I think, again, the transfer at 16 years is critical. I think at the time of transferring from the children's clinic to the adult clinics, a decision needs to be made whether the child is normal, and we have suggested some methods of doing that, whether there is no evidence of coronary involvement, there's no long-term risk, then again the family should be reassured and the child could be discharged, separating out from those children who are now going to become adults who need a very specific follow-up, again ideally in a clinic where the cardiologist is familiar with Kawasaki disease, knows what to look out for, knows how to investigate the child in the long term. So I think it's separating those who are well from those who need specific follow-up. And just because the aneurysm appears to have settled, we currently recommend that those children should have aspirin long term. If they had a coronary aneurysm, they should carry on their aspirin at least until the end of childhood, where that point of assessment should come in.
Damien, we've been talking about the UK lifetime management guidance and the fact that this is now in place. You're working in a paediatric setting. Are you aware of cohorts of children who have previously had Kawasaki disease who are being treated in accordance with lifetime care guidance?
So I suppose I'm afraid today I'm not, but my field of practice won't always put me in those kind of the circles where those children might come to my attention. What I would say is that there are a group of children who present to both emergency departments and general practitioners and maybe other child health professionals who I think, and this isn't just for Kawasaki's, this is for all conditions which might not be as common as others, who parents should be empowered sometimes to suggest that they may know a bit more than the doctor that they're seeing. And I'm always very grateful if a parent comes with a condition and says, look, this is what's happened to me, and this is some guidance which you might not be aware of. Would you like to take a look at it? And I don't think any doctor should take that as a challenge or something that says they don't know what they're doing. As long as it's a kind of an endorsed piece of work, there's a great opportunity there for some shared learning. And I suppose so. I don't come across these patients very often, but if a parent was to present and say, look, these are some of the recommendations that have been done for long-term management, here you go, would you mind having a look at them? I'd be very happy to do that.
Tom, did you want to come in?
Yeah, Rachel, I'd add in there in terms of one of the key aspects, I think, which, as Damien alludes to, maybe shifts away from the childhood setting more into the adult setting, is an awareness of the fact that children with, or now adults with Kawasaki coronary disease may present abnormally. So they are at risk, but they're younger than the normal patient that presents with heart disease. And so although we as individuals might mop up all the information a parent might give, I think when a young adult presents with chest pain, the paramedic or the busy A&E may disregard them as being low risk. And so one of the key elements of the lifetime management process has been to give patients a PSP, a person-specific protocol, which is really just an identifier to say, recognize that this person is at risk and take them seriously, even in the absence of maybe the normal bog standard symptoms that patients present with a heart attack. And so, you know, we include within those protocols, and we've only released a handful so far from our practice, but we include there our contact details so that day or night there can be some engagement with a team who have a greater level of understanding or expertise. And I think that's critically important.
Thanks, Tom. Could we stay with you just for a moment in relation to the risk associated with living with a giant aneurysm?
Yeah, so we've already touched upon that in part. So this concern that having a swelling, an aneurysm of the heart artery places them at greater risk of forming blood clots on the one hand. And so thinning down the blood is important. And as I said, there's a small number of patients year on year that present to our practice young for having a heart attack, but having one because they have this kind of stagnation of blood, this clotting of blood within an arterial swelling. So that's the first element. And then the other has been touched upon by Paul, where you may get this ongoing process within the artery in terms of thickening of the wall, which leads then to narrowings. And so that probably is the element for us that's most challenging long term in terms of trying to understand whether that's causing an upset in blood flow and potential symptoms. So that's where the year on year or every second year surveillance becomes very important. And we increasingly relying upon MRI, or I've already mentioned stress exercise tests as a means of trying to assess the risk.
Thanks, Tom. 75% or thereabouts of children affected with Kawasaki disease don't have cardiac complications, but parents are worried necessarily sometimes about what that might mean for them in terms of lifetime care. So Rob has touched on that his practice, children can be discharged if they show no signs of aneurysms and are otherwise well after a period. Are there any lifetime care management considerations for a child who's had Kawasaki disease but no heart complications?
Tom said some very wise words at the beginning. So back in 2002, Rob and I and some others were involved in writing some UK guidance, and we made a statement that whilst there were significant degrees of uncertainty, children who have had Kawasaki disease may be followed up long term, and we advised that GP follow-up might be appropriate for patients without any cardiac involvement. Then what happened was there was a response to that paper that was published in Archives of Disease in Childhood, saying that was going to create a lot of unnecessary anxiety. In other words, what's the point of bringing back a child years later with a completely normal heart? And then one thing that we became aware of was that, in fact, it was the opposite, that many parents had ongoing worries about their child, even with normal coronary arteries, and we're restricting their activities unnecessarily. And by bringing children back, even with normal heart findings, we as clinicians were able to reassure parents that, in fact, no, they could lead a normal life. And so the impact on the children's life was the opposite of the anxiety that we were perhaps accused of generating. So I think that if you have a GP who is familiar with Kawasaki disease, even at some cursory level, to be able to give common sense advice to prevent unnecessary restriction of activity, then that's a very good thing.
From my point of view, it's been an absolutely fantastic conversation. I'm hugely grateful to all of you for the time that you've given. I'm very grateful too to our families and patients who put the questions to you and took the time to do that. I know this will be voraciously consumed as a video when we publish it on World Heart Day. Have a lovely rest of the evening, and thank you very much indeed.
Thank you, Rachel. Thanks for organising it.
Take care. Thanks a lot.
Bye now.